I just wanted to share a moment. So I didn't know about CFRI until I read The Power of Two memoir and also watched the movie. And so we were committed with another patient of mine to host a screening of the movie back in 2012. And Isa and Anna joined us, and here they are on the big screen at this incredible theater. We had food trucks, we had other people join us, and on the stage were our transplant directors and transplant surgeons to talk about transplants, as well as breakout sessions talking about exercise and airway clearance. And it was really an incredible event, and it was all really through the strength and kindness of Isa and Anna that really drove that. And there's a saying in Turkish that the kalp yüzün aynasıdır, and essentially saying that your face is your shows your soul. I can't believe I can't remember the words, but essentially like your face is a mirror to your heart. And Isa is just one of those people, and so is Anna, that you can see in their face that incredible heart that they have and that kindness. And really just, we're all going to miss her. And I did share this with the family yesterday, and I was hoping that I did this yesterday, but we will all miss Anna. It was really wonderful to talk about her yesterday and to share with her family and to hear from her husband. But very quickly, CF is a story of progress. We all know that for 90% of patients that, things have evolved to a point where last year, in 2021, actually, we had 10 people with CF run the marathon, and Katie O'Grady is one of those incredible folks who is here, describing it on the CF community blog, at CF Foundation community blog. And there's hopefully a documentary that's going to be coming out very soon about that. And here she is. At CFRI and Siri, and thanks to Siri, have joined together with the Parent and Advisory Roundtable, or the Public Advisory Roundtable. I'm blanking on that. And CFRI, and we invited Katie, or Siri invited Katie to give a talk, and here she is talking about her experience. And it's really, I want to show this because that's sort of emblematic of the change in how we, see CF. I mean, this is really an issue with people getting older and facing new challenges. And I think no longer can we say for at least 90% of folks, and I don't want to forget those 10% of patients who don't have access to modulators, who are really struggling with CF in the way that we have known it in the last 10, 20, 30 years and beyond. But lung disease maybe isn't the major morbidity and mortality that people are facing with CF, and that we're seeing that in these age cohorts, looking at from 1991, 1995 to the age cohort in 2011-15, that we're seeing an improvement in lung function. On the graph on the bottom, we're seeing that exacerbations, the need for IV antibiotics, traditional treatment of exacerbations, they're going from a traditional if 50% of individuals on the left axis to all of a sudden dropping to hardly any patients are have been in the hospital in the last 3 or 4 years, compared to what we're used to before. And we're just changing the way we're practicing. And then we have so many people, Tracy Kazmersky, Jen Taylor-Kozer, Raksha Jain, and others in the community talking about sexual health and fertility and pregnancy. And we can see back from 2018, 2019, there's a significant jump that is now sort of stabilized in that we're seeing all these increase in pregnancies. And we know that prior to modulators, there was a 35% infertility for women. But now we see, cervical mucus thinning. We see improved cervical and uterine pH, which is probably a major factor in improvement in implantation and fertilization of the egg, and then improve, in nutrition and improvement in delay of puberty and anovulation. That's leading to, what we're seeing here. And there is always been that concern with taking modulators, new medications, and especially ones that haven't been tested as far as fetal exposure during those clinical trials. But there's that, and this is from Jen Taylor-Kozer and Joe Paluski and Catherine Ramos, and may have like messed their first name up, and I apologize. But put together an article, and this is one of the things that they cited in there as well, is that there's a risk to the fetus based on very little data. But I think that discontinuing these highly effective modulator therapies comes with maybe a greater risk because of the decrease in health, decrease in weight, and also risk to the infant and the fetus if the parent isn't doing well. So there's been observations about this, and I'll quickly go through this, but Christopher Fortner and others in Connecticut described mothers who have CF taking modulators who are now having a child with CF, but is passing and not being detected with newborn screening because of improved pancreatic function. So one of the tests that we do is look for evidence of inflammation of the pancreas, and we're not seeing that. And so newborn screening might miss some of these newborns. And this is a case describing that, but then also Patrick Flume and others describing a case of a parent who knows that they're going to be having a child with cystic fibrosis and taking a modulator, though they don't have CF, so that their fetus is exposed to this new modulator to help a child not be born with a meconium ileus, a very highly risky event that a baby can be born with, requiring surgery. So, and that was successful in this case. And then now we're seeing, this potential use in other cases as well. And, are we going to find that, males may not be born with infertility issues or their pancreas functioning? These are things that were at the last CF conference. We talked about some of the ethical issues with giving a mother who doesn't have CF these very expensive and also drugs that may not be necessary for them. We're seeing a decrease in lung transplants. As you can see, this is collected data looking at up to 2022, and I think the numbers are still decreasing. So we know that CF is a multi-organ disease. So we're looking at sinuses still being issues, the pancreas, not just for absorption and decrease in pancreatic enzymes, but also leading to diabetes later in life that we'll talk about. The GI tract still is problematic and can cause constipation and blockage. We're still dealing with infertility in men especially. And then, there is still disease in the lung, even though maybe it's a little bit less problematic. It is still actually problematic for many of our patients who have advanced disease already. But then we know that CF impacts the liver and the gallbladder, bone health. The CFTR is not only affects vitamin D absorption, other things that can impact bone health, but also within the bone microarchitecture. We're seeing evidence of pulmonary cardiac issues, but perhaps in the form of cardiovascular disease. And then the spleen and, there's an Arnold-Chiari malformation that I won't go into, but there's associated with CFTR just for sake of time. But essentially any tube in the body that where there's a lining and there's an epithelial cells that are involved, it has CFTR, and when that's not functioning, there's a problem there. And then we know that depression and anxiety is also playing a huge role. In 2021, at the registry data, this is what we saw as far as the causes of death. And we know that respiratory failure has been the predominant driver of deaths in our community, unfortunately. And here we see that that number has dropped to 44% and transplant related to 20%. And then there's this unknown or other, and we're seeing these numbers likely related to cancer-related deaths, but other things as well. And you can see here that suicide or drug overdose, some of the problems that we see in the community also involve in the non-CF community involve the CF community, but other, and other things here as well, including heart attacks. In our patient population, back in 2022, we had a number of people that we lost. Heart disease, overdose, and cancer were some of the leading reasons for that. We know that diabetes, we talked about the pancreas and its the impact of CF on the pancreas, so leading to needing pancreatic enzyme supplementation, but also leading to islet cell destruction and needing supplemental insulin for treating diabetes. And here you can see that 40% of people by the age of 40 will have diabetes. So that's a game changer. There's a whole other chronic illness that people are having to deal with. And then also the fact that, it does impact mental health as well. And that number can go up to 50% by age 50. But we also see in that red graphic the number of people with impaired glucose intolerance. That is a precursor or a sign of potentially being diagnosed with diabetes, in the next few years. But we can see that if you diagnose somebody early, and that's why screening is so important, that you might be able to limit the changes in the impact of diabetes or insulin need through diet, or maybe treating intermittently with insulin when you're sick or on steroids. But insulin is really the number one way we treat that. We know that modulators can help those with mild disease or maybe reduce the amount of insulin you need with more advanced disease or when you've had diabetes for a long period of time. But early diagnosis can help with all of this. And impact of diet and exercise is really critical. I don't have that here. But with the advent of chronic glucose monitors, insulin pumps, how we manage diabetes has really changed. People are really more engaged and understanding that before, if you were looking at a lower life expectancy, maybe you're not as, vigilant with your diabetes. But now we know that people are living longer and you really need to be planning for the future, and not taking care of your diabetes can have implications in the future that we'll talk about, which I'll talk about right now. And some of it is this, things that can affect your body through diabetes and high blood sugar is for either microvascular or macrovascular disease. And a microvascular, we're looking at, impact of vision. That's why people with diabetes have to see an eye doctor regularly. You can see, kidney issues and chronic renal disease. And needing sometimes dialysis. You can have problems with sensation in your skin and your feet, and that can lead to, even, tripping and falling, but also losing, your foot to an infection that you may not have, saw that was happening early on. And then also you can have low blood sugar, also as a complication. But macrovascular disease, where these are things that we're seeing more and more now. I had a patient who had diabetes for much of her life, and at age 38 had triple bypass surgery because she had chest pain with exertion, sent her to a cardiologist, and within a few weeks underwent surgery. So she had multiple blockages, and this was likely because of poor blood sugar control for so many years. But we can also see strokes in addition to heart disease and peripheral vascular disease. So this is a graphic that Dick Simon, one of my mentors, along with Mike Boyle, when I was first starting out, those are the people that I went to learn about, how do we treat this aging population, even back in the early 2000s. But we can see here before and after modulators. And on the left, we're looking at a graphic of nutrition and weight. And on the right, we're looking at a graphic of high blood pressure. The black column is pre-modulator or pre-treatment, and the white is after modulators. And you can see here that we have a lot, wonderfully less people who are underweight. But then we also have less people who are of normal weight after modulators. And you can see here, overweight and obesity has increased after modulators. And then blood pressure as well. Here we see that normal blood pressure has gone down, and that's a real concern. But that elevated blood pressure and stage 1 and stage 2 hypertension have increased. And I think that this is a really important observation for us as we look to mitigate some of the complications going forward. I think that this, either is from lifestyle, from, potentially a result of modulators. We don't know. We know that Orkambi was associated with this, and now we're looking to see if, Trikafta and other drugs are part of it, or is this because of increased weight and other lifestyle, things that are going on? But we know that, that heart disease is something that was not necessarily recognized. There was studies that were misleading, showing that perhaps people with CF were protected from heart disease because their inflammation was really directed towards their lungs and their hearts were, protected. But we know that that's not the case. And we know that now, there's obesity and hypertension and diabetes, and these are all things that are leading to more heart disease. Actually, diabetes and hypertension together are the risk factors for internists. they look at those two things together, and we put people on statins by age 40, even if their lipid levels are normal, because we know that that's such a high risk. And so these are, things that we're going to need to do, and we're going to have to recognize and let our patients know about. But our diet used to be, that we were complicit with was, nutrition poor, saturated fats, excessive sugar, in order to just increase your calories. And that kind of diet sometimes is hard to break away from, after modulators. And, what do we do, in trying to make sure that, that is going towards a different style of diet. And that affects the gut microbiome. Gut microbiome impacts a lot of things, including cardiovascular health. And so we need to make sure we're dealing with that. And then, and we talked about modulators. And then there was a study looking at COVID-19 and screening people for heart disease. And we saw that there were, people with cystic fibrosis were coming in, and 22% had evidence of ischemic heart disease. And so that is a real sort of flag saying that this is something that we need to recognize. Certainly COVID-19 is playing a role, but I think this is also something that we need to pay attention to. And there's this wonderful fellow at Brown University who we're working together with. We're going to be doing calcium scores of coronary arteries, looking back at old CT scans in order to better understand the degree of risk that's in our CF population. And just very briefly, on the left, on the top is established states, and the bottom is modifiable states. And the middle is a graphic from endothelial injury, or like graphic on how heart disease and coronary disease, happens from left to right, to lipoprotein infiltration, cellular infiltration. So that's the the inflammation, and how these plaques filled with sort of fat and calcium can rupture and cause someone to have a heart attack. We know that protective things are having better lipid profiles, which people with CF have had, but not, before modulators, but not so much. And then also, lowering the rates of diabetes. Other things that you can modify, most of our patients, thankfully, but not all of them, smoke. And they've had low blood pressure, as we showed, pre-modulator, and lower BMI. And now we know that those are things that are reversing. And so we're going to be, this is something we need to pay attention to. We know that people with CF have chronic inflammation. They have, pulmonary hypertension from their lung disease. They have diabetes. Those are things that we have to do a better job treating. But the things that they can modify is, just adjusting your diet, and exercising is going to be a real important component. So, and then as I'm going to pass some things on to Anna, I also want to just touch on bone disease, because this is also really critical. People with CF have to be screening for bone health and osteopenia and osteoporosis. So we need to watch, the diet can have play a big role in that, making sure you're taking your calcium and vitamin D. Vitamin D deficiency is still an issue, and making sure that we're supplementing with that. But exercise is also going to be a critical part of that. There are things that we're seeing in the health of just people in general, and that's because our children in this newer generation are perhaps not as active. And diet has been a problem. And so, exercise is really the way to maintain your health for all of us, and including people with CF, even more importantly. So we need to screen and treat early, because once you lose your bones, your bone health, you lose and begin having osteopenia, osteoporosis, it's not really possible to get that back after age. In our late 20s, we stop building bone. And so now it's just really about maintaining it. So as we age, we want to make sure that we're doing the things so that we're not losing any more of the bone architecture. And thankfully, CF modulators, CFTR modulators help with that. And Melissa Putman, one of our colleagues, showed that in a nice publication. Also, there is an infection that continue to happen. Lung infection, we've seen the airway microbiome change for people with CF, but this may also be a reflection of the fact that we're not getting as many sputum cultures. People aren't coughing up as much sputum, so we're checking their microbiome through throat cultures, which may not be as accurate. So we're seeing a decline, as you can see in that blue graphic, or the blue line with the circles. That's Pseudomonas, and that prevalence of that seems to be going down, but that might not necessarily be the case, but it looks like here. And also even MRSA, a more drug-resistant form of Staph aureus, also declining, but we still have these drug-resistant organisms. But the CF Foundation, had a commitment to put in $100 million to start to advance more research in, if we're finding different antimicrobials, because we know that this is still going to be something that we're contending with, and also is going to help the general population as well. So we want to make sure that we're detecting and diagnosing and preventing and treating these emerging infections and emerging drug-resistant organisms that are there. I talk about all the time, and the best way to sort of mitigate this is infection control. So that's something that we do. But we also need companies to be able to invest in antimicrobials. Now, there isn't as much profit, so there needs to be other ways of trying to get companies to really invest in building in our armamentarium and antimicrobials to make sure the cost isn't getting in the way that the hospitals don't even stock them. But this is one of my patients who just was on, been invited to talk for the Senate subcommittee on superbugs and impact of antimicrobial resistance on modern medicine. It's really quite amazing, and she's now been interviewed multiple times, but she gave a very passionate statement on how CF and infection continues to impact her. And it tells you that, even though we're seeing exacerbation rates going down, it doesn't mean that intermittently that people aren't dealing with infections that are life-threatening still, and that we need, more agents to be able to fight them. And in fact, she was part of a clinical trial she talked about, which I'm going to come to next, on looking at IV tobramycin way long ago, and she developed hearing issues from that, because we know that some of the things that we do can cause not only kidney disease and hearing issues, but she was someone who suffered from that and shared that story. And so we need new antimicrobials that are safe to be able to do that. And I just wanted to touch on the fact, something that I've talked at, at a CFRI event before, but along with my colleague, Dr. Garanis, up in Oregon, on the importance of protecting ourselves from some of the medications we give. And aminoglycosides are one of them. That is another term for tobramycin, amikacin, the medication that treats Pseudomonas. But we know that we can monitor for toxicity by looking at the blood. And by the way, being very direct at looking at airway under the curve or pharmacokinetics of how these medications are delivered actually did stop our identification of hearing and kidney disease in our population in a short study that we did that I won't go into right now. So actually knowing about it and following it and appropriately monitoring it can have a significant impact. We know that you can have neurotoxicity and dermatologic reactions from this drug, but we can observe those. One of the things that we don't observe, though, is hearing loss. So if you're not routinely monitoring and screening, you may actually miss early signs of hearing loss, and you may give these medications again and again, and progressing the hearing issues. And so we have an algorithm. I'm not going to share that today, but you can look at a previous talk about that, or we'll do that another time, or you can reach out to me, and making sure that we're screening this on a regular basis. And we did a study using a hearing testing that was in the clinic, point of care therapy. And we actually noticed that there's other antibiotics that can cause hearing loss. And one of them was vancomycin. And so we need to make sure that, we're recognizing the side effects of medications and monitoring, so that we can, prevent from getting worse. Actually, this is a slide. I thought I took it out, but here it just shows that this was a study looking at a cross section of people in our clinic, as well as those serially getting their hearing tested while they're on IV antibiotics. In the top right corner in the box, we show we had 7 people on IV aminoglycosides, that's what the AG stands for. 0% of people had hearing loss detected acutely while they were in the hospital. But of the 80% of people on IV vancomycin did have hearing loss. So that's where I'm getting that information. This is yet unpublished data. But essentially, we had this portable sound booth that was donated by a company, and they unfortunately took it back. But it is, that's, another way of hopefully being able to increase our ability to detect that. So another thing I'll just touch on is also, just mental health. And here we can see all these complications have stabilized or coming down, whether it's, hemoptysis or ABPA, osteoporosis, All these are still like huge issues. But one thing that continues to rise is depression and anxiety, and that's what we see in the blue line there. We know that since 2018, there's been an increase in depression and anxiety, as stated in this 2022 registry report. And we know that the pandemic happened during this time, so that's also playing a role. But also, Dr. Snell, a psychologist in our program, did a study looking at mental health outcomes during the era of modulators. Now, the big confounding issue here is that this was during the pandemic, but overall, we know that what she found was that there wasn't, and this is also unpublished data right now, we're submitting it as we speak, but that overall that it didn't have a negative impact on mental health. But modulators were sort of like very patient specific. Some people had improved mental health, some people had decline in mental health. But we also know that there's some people who are very sensitive to modulators, very few that where discontinuing the modulator becomes necessary due to that, although that's a very small population that we're trying to learn more about. But in general, the fact that being on a modulator was not associated with this overwhelming improvement in depression, anxiety, sort of may reflect the pandemic, but it also reflects on this. One of my colleagues who wrote an article about this in the New York Times, this existential threat of living. I mean, the fact that people are living longer, now we're needing to deal with, age-related issues and, arthritis and saving for the future, complications like cancer. This adds, to that pool of things that really impact mental health. But here really we want to focus on sort of the major theme. I've sort of given a lot of other things to talk about, but I want to introduce Anna to share her story, and also share with you some like a crisis that we're facing, and that is the increased risk of cancers in general, but also colorectal cancer specifically. So I'm going to invite Anna and to share her story with us.
Okay, hopefully everyone can see me and hear me now. I have podium trouble all the time, so thank you for finding me a sturdy box to stand on. So good morning, everybody. First, I want to thank Dr. Uluer for such a kind introduction. It is really so meaningful for me to be here and have the opportunity of presenting with you. So thank you. I also want to thank Siri and my CFRI family for the love and kindness you have shown me over the last few years. I wouldn't be here without you all. And I know together we will save lives. For those of you who don't know me, my name is Anna Payne, and I'm grateful to be here today and share my story. Over the last 36 years, CF has caused me to take countless pills, spend months in and out of hospitals, do hours worth of breathing treatments, just to stay healthy. As these new breakthrough medications started getting approved, life with CF became less of a burden. And that medicine gave me hope that I could live a longer, healthier life, something we all deserve. But on July 21st of 2021, at age 34, I was diagnosed with stage 4 colon cancer. It's been 2 years, 730 days, 17,520 hours of being a cancer survivor. And let me be honest with you, it feels more like an eternity. But I know I'm one of the lucky ones. And that is never lost on me. In June of 2021, I noticed a dime-sized mass in my groin. So I went to my OBGYN, who sent me for some tests, and then to a general surgeon. In the meantime, the mass just kept growing, and I knew, well, that's not normal. By July, the mass was the size of a walnut. No one seemed to know what it was. In the meantime, I had also developed some digestive symptoms that masked CF digestive symptoms that I hadn't really had in a while. So I alerted my CF team, and we thought I had dios. So he did a few colon cleanses in a row. And while they did help, there was still an issue. After all of the cleanses, I was convinced that the mass and the digestive issues were part of the same problem. I alerted my CF team that I couldn't wait any longer to find out what the mass was. I was in the middle of waiting for a CAT scan that was ordered by the general surgeon. Thankfully, my CF doctor sent me to the ER immediately and ordered the same CAT scan I was scheduled to get in a couple weeks. After 2 days in the hospital, with more tests being done and everyone being stumped, I asked for them to biopsy the mass. I was convinced it was something serious, and I felt like no one was listening to me. It took me 4 days to get that MRI and a biopsy that I had asked for on day 2. I was released to go home for the results, but before I did, a team of doctors came to talk to me. I was in my room alone, and they came in and very casually told me they believed the mass would be malignant. I was glad I had CF because I could kind of roll with the punches. But I clearly started to cry. And one of the doctors sat down next to me and told me that my life was about to get harder. I remember waiting for the biopsy results was probably one of the hardest things I've ever had to do. I knew my whole life was up in the air, and I was positive it was about to get flipped upside down. That brief reprieve from that miracle drug Trikafta was quickly swept away. And I was transformed back into that young little girl whose future felt so very uncertain. A week or so later, my CF doctor called me and told me to come in and see him because we had to get a plan together. I kept begging him to just tell me over the phone, but he wouldn't. My friend Ashley came and picked me up, and we met my mom at the office. When he walked in with a box of tissues and tears in his eyes, I knew everything my body was telling me was right. I was unfortunately right. And I never wanted to be so wrong. My CF doctor broke the news that it was colon cancer, and it was aggressive. But they would do everything they could to help me. I remember the look on my mom's face and my friend Ashley as well, as he said it out loud. I had been telling them both for a couple weeks that I believed I had colon cancer. Seeing the look on their faces and hearing them whisper, "Oh my God, she was right," is something that will be forever embedded in my mind. I spent what felt like 2 hours crying in the office as the whole CF team came in to cry with me and hold my hand as I repeated, this was not fair. And it is not okay. And how I just wanted a break. I thought I was going to get a break. I'm so grateful for my CF team as they are the reason I'm standing in this room. They believed me. They advocated for me behind the scenes. They called the top oncologists in the hospital system and got me appointments ASAP. Less than a week later, I had an appointment with an oncologist, Dr. Lin, who confirmed it was probably stage 4 colon cancer. But just to be sure, I had to do a PET scan, and I still had to get a colonoscopy. I also had to get a port. I made it to 34 without a port. And now here I was, needing a port for cancer. The irony is never lost on me. The results from all the tests showed that I had a mass in my colon on both ovaries, some lymph nodes, and over 10 spots on my liver. The cancer silently lived inside me for years without me knowing it. It basically had a party inside my body. Someone gave it the keys to the palace and it was running wild. To count over the last 2 years, I've endured 2 rounds of immunotherapy, which did not work and caused me to need an emergency procedure. 42 and counting rounds of chemotherapy, which I still do every 2 weeks. A major surgery, plus countless progress scans, which are maybe the hardest part of being a cancer survivor. Anxiety is real, everyone. I spent the better part of 2021 wishing that my life was different, wishing that the cancer was all just a bad dream. And at some point I would wake up, just like Dorothy did in The Wizard of Oz. I did wake up, and unfortunately the cancer wasn't just a bad dream. But instead of continuing to wish things were different, I chose to learn something from the cancer instead of just hating it. Don't get me wrong, we're not best buds. But I realized that sometimes life gives you a journey that you don't understand, but it is within your control to decide how to handle it. And I decided that my life was worth fighting for, and that living is the greatest gift we are given. And hope was a story I have known my whole life. And that as long as Dwayne Johnson loved me, everything was gonna be all right. I was reminded that my power was actually in my pain. Oh, there he is. That I needed to share my story, and that my purpose would be greater than my suffering. I want to do everything I can to make sure this doesn't happen to anyone else. We all know that living with CF is hard. And I'm here to tell you that we don't need to add cancer to the mix. We now know that CF patients are 6 to 10 times more likely to develop colon cancer due to the genetic defect caused by cystic fibrosis. And yet the screening recommendations for CF patients who have not had a transplant, which, as we saw, transplants are on the decline, so there's more of us, shouldn't start until 40, a number that is way too high. Colon cancer in general is on the rise among young people. So much so that in May of 2021, the US Preventative Services Task Force lowered the screening age for everyone from 50 to 45. A recent publication by CNN discusses that colon cancer is a borderline epidemic among people younger than 50, with Generation X and millennials being at a higher risk than our parents' generation. And researchers are still trying to figure out why. Unfortunately, when cases are found in those of us below the screening age, the cancer is usually found at a late stage, like mine. When it is found at a later stage, especially stage 4, there is only a 14% chance that that person will still be alive 5 years after diagnosis. I'm holding on to faith that I will beat that statistic. Finding it early is paramount to survival. When it is found early, it is one of the most treatable cancers. By 2030, researchers predict that colon cancer will be the leading cause of cancer deaths in people between the ages of 20 and 49. If we know all of this about the elevated risks for the general population and CF patients have even greater risk, why haven't we changed the guidelines to allow patients to access a colonoscopy? When I asked this question in 2021 to those who set the guidelines, there were 2 answers I received, both unacceptable to me. The first one was, when the data shows a need for change, we will adjust. And I thought, given all of the above information I just gave you about the general population and the fact that we are at a higher risk, the age was just lowered 2 months ago. Shouldn't that be enough? In my opinion, it seems as a society, we have dehumanized healthcare so much that when people talk about data and numbers, it seems too often people forget that those numbers are human beings. I really feel COVID increased this thought process. They are our loved ones. They are our friends. They are, well, they're me. When I hear we can't make changes because the data doesn't support that yet, what that really seems to me is that not enough of us have been diagnosed with cancer. And not enough of us have lost our lives to this silent killer. So I'm begging you to see us, the ones who will have to sit in the chemo chair every 2 weeks, the ones who will lose our hair, our sense of self, the ones whose lives will be forever altered, the ones who will grieve, who will forever have to live in the uncomfortable. I beg you to see us. I have reached the top of the cancer floor. There is no higher stage than 4. It is too late for me. There is no walking away from this disease right now. As of now, I will continue to do chemotherapy every 2 weeks until science and medicine find something better. That is okay. I have made peace with this, but I will not make peace with the idea that other people will have to walk in my shoes when it does not have to be this way. We can't give out a miracle pill with one hand while simultaneously ignoring the elevated risk of developing GI cancers with the other. If you are a carrier, you're also at an elevated risk for developing colon cancer. So it's not just CF patients. The second answer to my question was when they see more patients requesting colonoscopies at younger ages, then they would consider lowering the age. I'm sorry, Dr. Uluer, maybe you could tell me, but I'm pretty sure no one calls their doctor to say, hey doc, I'm free this Monday, so can you hook me up with a gallon and go lightly? My friends are bringing a case of toilet paper. We're having a colonoscopy party. Doc, does that work for your schedule? Pretty sure if I had to make an educated guess, I'd say that probably never happened. But I took that answer as a call to action. That change will only occur from the bottom up, pun intended. So we have to be the ones to advocate for changes, and we have to demand better for each other. So I'm begging you, if something feels off, don't write it off or ignore it. Go talk to your doctor and get checked. Right now, a colonoscopy is the only test that can eliminate the risk before it turns into cancer. My life has completely changed, and it will never be the same. There's no going back to normal, whatever that means anyway. Some days it feels like the Grim Reaper is looking back at me when I look in the mirror. And other days he feels more distant. It's nothing short of a miracle that I am here today. Over the last year, I had received a clear scan for 6 months straight. And I had hoped it would allow me to get a break from chemotherapy. But in May of 2023, they performed a PET scan and found new spots. So no break, no reprieve. Back to heavier chemotherapy drugs that I had the privilege to eliminate back in June of 2021. This is life with cancer. And I hope my next set of scans in a month shows a response. But regardless, this is my new normal. And until the screening age is lowered, we will unfortunately have more people living my new normal. And not everyone will have the same kind of luck I have had. So I hope you will help me honor those who are no longer with us by educating those who are. I have had to learn how to relive my life. I have spent months and days grieving the loss of a life I thought I was going to get to have. I have lost friends. But I do want the record to reflect Since I'm a politician, that's usually how I say things that I want people to really remember. I don't suffer from stage 4 colon cancer or CF. I'll live with them. I'll thrive with them. Because if you do the math, there are always more good days than bad. Thank you.
That was amazing. When Anna shared that speech with me before, there was like, there's nothing you need to change. That was like perfect, and just shows what a strength of character, just incredible human being you are, and to advocate for people who you want to protect and you want to save their lives. I mean, you're just an amazing human being, and just thank you for sharing all of that. And I wanted to make sure that we had time for Anna to share all that. And this is a quote from her: "A cancer journey is waves of constant grief with a thin line of faith that you have to hold on to in order to survive." And I mean, I just think that I'm so thank you for sharing that. And I will briefly just share with you some of the information that she shared. And we talked about all those other things, but really cancer is one of those diagnoses that just sort of changes everything, because you're all of a sudden dealing with something that's just that you have to deal with immediately, and you can't put it aside, you can't ignore it. And people like Anna face it with courage and conviction, and that's the way to way to do it. And she's right, colorectal cancer, 5 to 7-fold increased risk, and then also an increased risk after transplant, which is just incredible, 25 to 31-fold. And 50% with adenomas compared to 11% of the general population. So there is an increased risk and prevalence in CF, and is also with esophageal cancer. But those are preventable because we can screen for those, and there are some guidelines for those. And every time our gastroenterologist, Steve Friedman, finds a polyp that looks adenomatous, looks precancerous, he will call me, he'll send me an email saying, "We got another win." Because that polyp that you removed would have been a cancer in 3 to 5 years. And so that's what we mean by it is preventable. And then, pancreatic cancer, gallbladder cancer. And by the way, there's other cancers that are increased risk of people with CF. And as Anna said, for our carriers, our parents in our community, there is an increased risk of these malignancies as well. And we don't have guidelines for pancreatic cancer. I will just briefly share with you that the registry here showing the age and per 100,000 people, looking at the prevalence of cancer in the CF population. That's that top curve that's going up where it says CFF registry, and you can see it going in a direction that you don't want to see, and so much different than the surveillance epidemiology and end result registry that's there for the general population. And you can see that significant discrepancy, and that's because there's inflammatory disease of the bowel, there's diabetes, that mucosal barrier I was talking about, not only in the microbiome in the gut, not only affects our risk for cardiovascular disease, but also cancer. Our nutrition, high fat, low fiber diet, vitamin D deficiency, these are also impact cancer. But then there's the CFTR related, those who have the class of mutations from 1 to 3, those with higher sweat levels with a cutoff of 100 millimoles per liter of chloride. There are people who have increased risk of cancer. And that CF carriers, as we talked about. And we know that CFTR gene is actually a tumor suppressor gene. So its absence is a poor prognostic indicator. And for people, so cancers in general affects, there's mutations in a lot of different ion channels and CFTR. So someone without CF who has cancer, who has a mutation within the CFTR domain, will see that their tumor is a more aggressive type. So CFTR really plays a role. Now, what we don't know is what modulators are going to do for that. And I've met, unfortunately, a number of folks during this period where Trikafta, has changed lives, but only to find that things are upended with cancer diagnosis. And so what she shared is, so just very familiar to me. And so we know that colonoscopy, endoscopy, the guidelines say that age 40, and then screening every 5 years or 3 years if you have polyps. But, we're questioning that. And, our gastroenterologist, Dr. Steve Friedman, we're going down to age 35 right now, and maybe even younger, because all those people that we know who've been diagnosed or fighting colorectal cancer, they're all younger than age 40, at least in our center. And as Anna stated, the American Cancer Society released a publication showing that a third of diagnosed of colorectal cancer is actually younger than age 50. That's why they went to 45. But there's people in their 20s and 30s. The thought is that diet and exercise is potentially maybe one of the reasons for that. But there's also other things like maybe increased smoking and vaping. But we're going down to maybe 30. I mean, where do we go? We're not exactly sure right now, but we're using, if someone's had a lot of inflammation in their bowels, lots of obstruction in their bowels, lots of inflammation, that's who we're recommending get earlier screening. But age 30 for those who are transplanted. And others, there's right now the nice CF study that's looking at fecal immunochemical testing to screen for cancer cells, colorectal DNA tests like Cologuard. These look at biomarkers and DNA and other markers in order to see if we can detect these things early. But what we do know is that when you do these tests, you're not one of them may be 90% sensitive, but we don't know if that's the case in CF. And also, you're missing an opportunity to remove a polyp. And then also these studies include those, even as CF, like it's in our clinical trials, over the age of 40 if you're pre-transplant. And that is also then sort of maybe missing that opportunity to look at a younger age population. So something that we need to look at. But there's no screening recommendations for gastric cancer or biliary or pancreatic cancer. Now, I was introduced to Anna through Pat Nash, and his sister is also here with us. And I would also add that, and also, they say that there's a publication in 2017 that looked at the prevalence of pancreatic cancer in general population, and then also in CF, and that the numbers are really so low that, one of the things they said in the article was that most practitioners will never see pancreatic cancer in their population, though there's an increased risk. We lost both of these gentlemen in 1 year to pancreatic cancer. And like I said about Isa, you can look at their faces, and Pat is from this community. He is a big, somebody who provided so much to CFRI and to the community. And you can see through his face and through his soul, his kindness, and just, what an incredible person he was. And also Jack. These guys were friends, and they were friends with Anna. And I know that I know Pat just was thinking about you until, the day he passed away, just wanting to make sure. And I know he talked to you, before that as well. So we need to do better. And right now we are screening for pancreatic cancer at age 50, but maybe we need to go lower. But these tests are expensive and there's no guidelines. And so we need to establish them. And that's hopefully something that we're going to be doing. And, there is screening that is done in the general population through mammography and vaccines and blood tests and lipid profiles. And, we have some guidelines for CF, but we need to make sure we're implementing them. And, now we've gone over, we started a little bit late in our presentation, but this is, a big, crisis. And, we're getting together with Pat's sister, Christina, and with CFRI and other, and Pat's incredible wife, Carolyn, and trying to come up with ways that we're going to make sure that we remember Pat. I mean, Paul Quinton mentioned that, remembering is the most important thing, to honor somebody. And we're going to remember Pat, and we're going to remember Jack, and we're going to make sure that we're honoring them. Because Pat, before he was diagnosed with pancreatic cancer, one of his goals was to improve how we're taking care of an aging population. And then when he was diagnosed with pancreatic cancer, it was all that more important that he do this and that we do this now in his name and in his honor.